صباح الخير. هنبدأ السيشن. بعلا مجدي, lecturer of diagnostic and interventional radiology, National Cancer Institute, Cairo University. The first talk will be about the interval breast cancer radiological surveillance in screening Egyptian population. فين دكتورة علا؟
Recording in progress.
أفندم. ما هو الدكتور ماهر قال هيجيبها واحنا شغالين. وممكن يا دكتورة علا انت لسه مش جاهزة؟ انت آلاء. امال فين علا؟ علا ما جاتش؟ آلاء يعني نتكلم بآلاء وخلاص. دي women imaging. طيب تمام. اوكي. دكتورة آلاء صبحي. What's beyond breast asymmetry? Comparative study between artificial intelligence and CESM in the assessment of various types of breast asymmetries. By Dr. Ala Sobhi, lecturer of diagnostic and interventional radiology, women imaging unit, القصر العيني hospital, breast imaging consultant at Bahia Hospital.
Good morning, everyone. It's my pleasure to be with you to talk about our research work which was done at Al-Qasr Al-Aini Hospital, which is about what's beyond breast asymmetry, comparative study between artificial intelligence and contrast mammography in assessment of various types of breast asymmetry. Okay. First of all, as artificial intelligence is the talk of this era, on your expectation, will AI replace radiologists in the future? Okay. We will answer this question at the end of the talk, and we will focus on artificial intelligence. Our aim of work, we aimed to investigate the role of artificial intelligence compared to contrast mammography in assessment of breast asymmetries and evaluate their performance as diagnostic modality among different types of breast asymmetries. This prospective study was done upon 64 patients who had breast asymmetry detected by either screening or diagnostic mammography on both CC and MLO view. Breast ultrasound was done for all patients, then each breast categorized using Piret classifications. Then, all patients were subjected to AI software and contrast mammography to evaluate what is beyond the breast asymmetry. Our strategy of evaluation was follow-up by single-view mammography after 6 months was used as a reference standard in benign cases scored by RATS 2 or 3. While patient scored by RAT 4 or 5 went for histopathological correlation.
دكتورة آلاء ممكن رجاء ممكن تراقبي بوقك الميكروفون شوية
تمام.
وتعلي صوتك عشان السبيكرز ورا خالص مش سامعين.
حاضر.
Thank you.
Okay. The patient age ranging from 27 to 65 years. The main presenting symptom was breast lump, followed by patient coming for regular screening, followed by mastalgia, nipple discharge, and nipple retraction. The most common of asymmetry was focal asymmetry, followed by global asymmetry. The diagnostic performance of AI and contrast, compared to contrast, the contrast mammography was more sensitive. However, the AI was more specific in diagnosis of different types of breast asymmetries. Although the diagnostic accuracy of both was close to each other. Our first case, 49-year-old female presented by left yoni orificial bloody nipple discharge. Mammography revealed left upper outer quadrant focal asymmetry with overlying microcalcifications. Targeted ultrasound revealed heterogeneous hypoechoic irregular shaped lesion, and AI revealed area of high abnormality score. The contrast mammography revealed left upper outer quadrant segmental area of intense heterogeneous non-mass enhancement. Pathology in this case was mucinous carcinoma with intermediate ductal carcinoma in situ, so AI and contrast were true positive in this case. Second case, 52-year-old female symptomatized with right mastalgia, breast redness, and tenderness. Mammography revealed right para-arear and retroarear focal asymmetry, tubular dynasties with overlying skin thickening. Ultrasound revealed retroarear dilated duct with mild mural thickening, showing internal echogenic content with no internal vascularity, likely in septated secretions. The AI shows low abnormality score. However, contrast mammography revealed right para-arear, upper outer quadrant, and retroarear linear heterogeneous non-mass enhancement. Pathology revealed periductal mastitis, so AI was true negative. However, contrast was false positive. Last case, 36-year-old female was coming for screening. There was a strong family history. Mammography revealed left lower outer quadrant subtle focal asymmetry with overlying few punctate microcalcific foci. By ultrasound, there is left 4 o'clock intramammary dilated duct directing to nipple, showing intraductal echogenic content, showing mild vascularity on color Doppler application. AI show low abnormality score. However, contrast mammography revealed left lower outer quadrant linear heterogeneous non-mass enhancement targeting the nipple. Pathology revealed ductal carcinoma in situ, so AI was false negative. However, contrast was true positive. The diagnostic performance of AI compared to contrast, as we mentioned before, revealed that contrast mammography was more sensitive. However, AI was more specific in assessing different breast asymmetry, although diagnostic accuracy of both was inconsistent with each other. All of these findings support the role of AI reading as a safe, valuable diagnostic tool in mammography interpretation, which will also improve efficiency of breast cancer screening program with subsequently reducing recall of patient, frequency of unnecessary biopsies, as well as short interval follow-up exams. We also concluded that AI-aided reading can replace contrast mammography in most cases, especially for those who have contrast sensitivity or impaired kidney function. AI also can reduce the radiation exposure hazard of the second dose of radiation for contrast and its financial cost as well. So, at the end, in your expectation, will AI replace radiologists in the future? The application of AI is meant to enhance the radiologist's performance, self-confidence, and not to replace him. Radiologists are indispensable and way more valuable to be replaced by AI. So, AI and radiologists are teamwork. Thank you for you all, and special thanks to my mentor and Professor Dr. Rasha Kamel.
دكتور علاء السلام عليكم. عليك اشمعنى لقيتوا الكونتراست انهانسد ماموجرافي versus الام ار اي فور اكزامبل؟
الكونتراست مور فيزبل عندنا في القصر العيني طبعا، واكيد فاينانشال كوست.
مش سامع.
انا اسف.
ممكن
هقرب المايك خلاص. تمام كده. برضو حلو.
باتر حبيبتي.
نعم تمام.
Better.
الكونتراست بالنسبه لنا طبعا احسن من الام ار اي، لان الكونتراست فاينانشال كوست اقل كتير من الام ار اي، وان هو فيزبل يعني عشان العينه تاخد ميعاد لكونتراست اسهل كتير من تاخد ميعاد للام ار اي. بس فهي يمكن هي اكيد في كونترا انديكيشن للكونتراست، ممكن الام ار اي يعني يبقى احسن، بس احنا طبعا خدنا الموست شيب اكزامينيشن يعني.
وهل السوفت وير بيشتغل بس على الماموجرافي ما بيشتغلش على على افلام الام ار اي؟
الايه يا فندم؟
هل السوفت وير بتاع الارتفيشال انتليجنس بيشتغل بس على
الماموجرافي بس؟
عشان كده بقى. اوكي ثانك يو.
اوكي ماشي يا فندم.
لا انا وراهم بس مش مشكله قدامه يعني. حضرتك جراحه؟ طيب ما حضرتك.
Second speaker دكتور أحمد عبد المعز. دكتور أحمد عبد المعز will talk about target axillary dissection to minimize axillary surgery post neoadjuvant systemic therapy in breast cancer prospective study. دكتور أحمد عبد المعز Associated Consultant Breast Surgery بهية Foundation Lecture of Surgical Oncology National Cancer Institute Cairo University. اتفضل دكتور أحمد.
Targeted axillary dissection to minimize axillary surgery, post-neoadjuvant systemic therapy in breast cancer prospective study. I am Dr. Ahmed Abdelmoaz Salim, lecturer of surgical oncology NCI, Cairo University. Breast cancer patients presenting with nodal metastasis often receive neoadjuvant systemic therapy, which can eradicate or minimize the breast cancer burden and nodal disease. Also, neoadjuvant systemic therapy can achieve pathological complete response, which improves disease-free survival and overall survival. Axillary lymph node dissection has been the standard surgical approach in node-positive patients. It's associated with significant morbidity such as numbness, pain, restriction of shoulder range of motion, upper limb lymphedema. That is low quality of life with unclear benefit in those who achieve a nodal pathological complete response after neoadjuvant systemic therapy. This led to the development of sentinel lymph node biopsy, which is a minimally invasive, reliable technique with high accuracy in determining the status of the axilla and led to less morbidity compared with axillary lymph node dissection. In patients treated with neoadjuvant systemic therapy, resolution of all nodal metastasis to pathologically confirmed node negative disease at surgical resection occurs in 40 to 50%, with rates of high as 60% in HER2 positive disease. Sentinel lymph node biopsy after neoadjuvant systemic therapy can provide a less invasive method for staging residual axillary disease after chemotherapy. There are three conditions of the axillary status in relation to neoadjuvant systemic therapy. Here we are concerned about the patients with node positive before neoadjuvant systemic therapy who confirmed to node negative after neoadjuvant systemic therapy. The dilemma is that if you performed axillary lymph node dissection for them, this may be I needed surgery and you get the pathology report 0/10 or whatever. And if you perform sentinel lymph node biopsy, high false negative rate, more than 10%, which is not a reliable technique for staging the axilla due to high false negative rate, more than 10%. This is a definition of false negative rate in our study. A meta-analysis done about the sentinel axillary management post-neoadjuvant systemic therapy showed that the false negative rate ranges from 7 to 36% in node positive confirmed to node negative subgroup. What is the effect of the chemotherapy on the axilla that leads to high false negative rate? It is due to fibrosis and shrinkage and emboli and debris depositions in lymphatic roots that leads to incomplete sterilization of the lymph nodes. So neoadjuvant systemic therapy also leads to decreased number of axillary lymph nodes retrieved in post-operative pathology. What is the problem that led to the elaboration of TAD? The problem is that there is high probability, up to 50% of axillary lymph nodes positive before neoadjuvant systemic therapy to become negative after neoadjuvant systemic therapy with hazardous non-beneficial axillary lymph node dissection. And sentinel in such cases has high false negative rate, more than 10%. So it is obvious that there is a high need for a new technique to resolve this issue and decrease the false negative rate and accurately stage the axilla post-neoadjuvant systemic therapy. Targeted axillary dissection is a new technique aiming at decreasing the false negative rate of sentinel lymph node biopsy in node positive confirmed to node negative patients. We depend on the CLEB for marking the lymph nodes, and some centers use radioactive iodine 125, others use the charcoal black carbon. Under trial with the magnetic seeds. The number of lymph nodes to be retrieved, most of the guidelines suggested that the number of lymph nodes may be less than 3, and if more than 3 or equal 3, axillary lymph node dissection. The technique of the TAD in our study selection of the patient from T1 to T3 with one pathological lymph node, and the MDT decision is neoadjuvant systemic therapy, fine needle of the node to confirm the diseased node pathologically, not radiologically. The patient will receive the neoadjuvant systemic therapy. Then after completion of neoadjuvant systemic therapy, assessment of the axilla again by ultrasound. If it's still suspicious axillary lymph nodes, we take fine needle again. If positive, so our decision is axillary lymph node dissection. If radiological complete nodal response, post neoadjuvant systemic therapy, intraoperative localization of the previously clipped node by ultrasound, and sentinel lymph node biopsy with dual technique to increase the detection rate of the sentinel lymph node biopsy by both dual technique, patent blue and technetium-99. Specimen radiograph of the sentinel and the clearance to confirm the presence of the clip. So we send the pathology specimen as the sentinel lymph node alone, the clipped node as a separate entity, and the completion axillary lymph node dissection. We had a challenge that the usually used clip is the titanium barred ribbon clip, which costs us about 3,600 Egyptian pounds, $120 US. In our study, we used the titanium isocon clip in half of our patients. So we were able to compare the efficacy of the titanium clip, which cost us about 15 Egyptian pounds, with the other clips that cost us about 3,600 pounds. This is a titanium barred clip. These are the clips that are present in Egypt. The barred ribbon ultra clip, USA, about 3,600. The Geotech from Turkey, and the Tomark from Germany. We used in half of our patients with the Liga clip, which cost us about 15 Egyptian pounds, with very high accuracy. Ways of intraoperative localization of the previously clipped nodes, intraoperative ultrasound, or iodine 125, or wire localization. In our study, we used the intraoperative ultrasound. Regarding the technique of sentinel, we used the dual technique, both technetium-99 and blue dye, to increase the detection rate of the sentinel. The number of lymph nodes, we removed at least two lymph nodes as a sentinel, and also any suspicious lymph node was removed. This is the preoperative, the day before surgery, preoperative assessment of the ultrasound of the lymph nodes, post neoadjuvant systemic therapy, just the day before surgery. This is intraoperative detection of the sentinel lymph node by using the Sentinella device in Tagamma Hospital. This is another case using the Sentinella device. We use it in the x-axis and y-axis to perform complete scintigraphy of the axilla and to detect the sentinel node by dual technique, both technetium-99 and radioactive colloid and blue dye. Here is the gamma probe. The new gamma probe, it came while we are working in the study. Another case. This is the axilla. We are searching for the sentinel lymph node by using the technetium-99 and the blue dye. This is the shape of the sentinel lymph node on the Sentinella device with high count per second. Another case. Another case. A new initiation in our study, we detected the site of the sentinel and the site of the clipped node in the zones of the axilla according to the new Clow classification of the axilla. This is a new classification for the axilla. It is not level 1, 2, 3, but A, B, C, D. We detected where we found the sentinel and where we found the clipped node in the 4 zones of the axilla. This is intraoperative, while the axilla is opened intraoperative during surgery and using of intraoperative ultrasound. This is intraoperative assessment of ultrasound for the cortex of the lymph node with the clip inside it. Another case. This is specimen radiograph of removing the sentinel and the completion axillary dissection with the clip inside the sentinel. In this case, the clipped node was one of the sentinel lymph node in this case. Another case. Another case. In MD Anderson trial, the false negative rate of the sentinel lymph node alone, post neoadjuvant systemic therapy, was 10.6%, while the false negative rate of the TAT was 1.4%. So here we can answer 2 questions. Either the sentinel alone.
المفروض نليمت البرزنتيشن ل 7 minutes بس. بعد عديت 7 minutes بتوعك. You should limit the presentation to 7 minutes and leave time for the discussion. بسرعة يلا.
So here we can answer 2 questions. Does the TAD alone can sentinel lymph node can stage the axilla? No. False negative rate more than 10. Can the TAD enough for staging the axilla? Most probably is, but further studies is needed. The false negative rate in our study was 16.6 for the sentinel lymph node post neoadjuvant systemic therapy. The false negative rate was TAD 5.5, less than 10%. So it is a reliable technique. We assessed the role of the TAD technique for detecting the false negative rate. We were the first trials that using TAD, using a clip and dual technique for sentinel. Our study provided a cheaper way for making axillary lymph nodes with much cheaper clip, so we can use the technique in low middle income countries with comparable result. And our study is the first study to assess the site of the clipped node and sentinel lymph nodes, the 4 zones of the new cloud classification. Other ongoing trials worldwide, the Magalene trial in MD Anderson, RISAS trial in Netherlands, CENTA trial in Germany, and Ghana in France. Thank you.
ثانك يو يا احمد.
Thank you.
انت شغال فين يا احمد الاول؟
انا مدرس في معهد الاورام واسوشيت كونسلتنت في بهاء.
طيب يعني الجهاز بتاع اللي بيقيس اللي بتقدر تديكت بيه التكنيشيوم ده موجود عندكم؟
ايه يا فندم؟
الجهاز
موجود. احنا عندنا 3 اجهزه في معهد الاورام وعندنا جهازين في بهاء.
الجهاز ده اسمه ايه؟
الجهاز الجاما بروب.
طيب
For
هو
the-
بيبقى معاك مين في العمليات يا احمد؟
انا مشرف على رسالتي كانت الدكتوره اميره حامد، هي استاذ مساعد اشعه، كانت بتطلع تعمل لنا انتربت والترا ساوند، وكان معايا اساتذتي المشرفين عليا دكتور حمدي ودكتور
طيب
فرحات.
ومين كان معاك فيزياء اشعاعيه؟ فيزيكس لازم في واحد
لا انا مش سامع
لازم
حضرتك.
يكون واحد معاك عشان البروتكشن. ازاي بتحمي نفسك يعني من الاشعاع او كده يعني؟
لا هو التكنيشيوم 99 الرول بتاعه في الاشعاع قليل، وايفن التكنيشيوم 99 كان بيوزد في
لازم يكون
البريجننت.
معاك يا احمد فيزيائي معاك.
لا انا كنت بطلع
حاسب.
اجيبها من الفيزيائي، وكنا بنركب التكنيشيوم 99
أصل
على
انت في
نانو كلويد.
العمليات انت وواحد تاني، يعني المفروض في الحالات اللي زي ديت لازم يبقى معاك واحد فيزيكس، لازم. بدون فيزيكس يبقى انت كده بتعمل هازارد، خلي بالك.
انا كنت عندي فيزيائي موجود في وحده البون سكان، كان بيحضر لي كل يوم النانو كلويد، بيجيب التكنيشيوم 99 يركبه على النانو كلويد ويديهولي.
مش قال لك اعمل حاجات بروتكشن
كميه
مثلاً
الاشعاع اللي في
كام
التكنيشيوم 99
سنتي؟
قليله، وينفع يستخدم في البريجنسي. السنتينل في البريجنسي بتتعمل بالتكنيشيوم 99 مش بالراديو مش بالبلو اي.
طيب تمام يا احمد. انت بتشيل كام واحده سنتينيل ليمف نود يا احمد عشان تبقى
بشيل
انت
اتليست 2 سنتينل ليمف نودز،
ليفل كام؟
واني سسبشس ليمف نود الاقيها كبيره لازم اشيلها.
يعني مش هتحدد ليفل 1 ليفل 2 ولا بتاخد جاست اول ستيشن من الليمف نود؟
لا انا الاول بشوف الكليبد نود فين بالسونار واشيلها كده، طلعت الكليبد نود. لو بالصدفه هي نفس السنتينل، وده حصل في حالات كتير طبعا، خلاص هي ملونه قدامي ازرق واخده قرايه على الراديو اكتيف كولويد، خلاص هي دي الكليبد نود، هي السنتينل، بريبورت ان الكليبد نود ايكوز سنتينل. لو لقيتها براها بشيل الكليبد نود لوحدها واشيل السنتينل لوحدها، وعشان الورك بتاعنا يكمل لازم اعمل كومبليشن دايسكشن في كل الحالات عشان اعرف في بوزيتيف نودز في بقيه الاجزاء الكلينيس ولا لا.
طيب يا احمد خلاص كده بالنسبه للتكنيشيوم، انت استخدمت كام حاله تكنيشيوم وكذا كذا
لا
حاله؟
كل الحالات كانت تكنيشيوم، كل الحالات كانت بلو داي.
وانت كتبت مسيلين بلو، انا شايفك كاتب مسيلين بلو في
الاثنين مع بعض، كنت بستخدم التكنيشيوم وبلو داي مع بعض في كل الحالات.
وده ينفع يا
دول
أحمد؟
تكنيك ينفع يا فندم، تقريبا لو انا ازرق وريها قاريه بالجهاز. ده هو لازم يا فندم ديتكشن ريت 78% بالسنتينل بالدول تكنيك، بوان تكنيك بتنزل ل 50%، فكان لازم استعمل الاثنين، واحنا الحمد لله اول ترايل في مصر تستعمل الاثنين مع بعض،
بالظبط كده.
البلو داي والدول تكنيك، واول ترايل في مصر استعمل الكليب.
اباوت التكنيك، انت بتحقن التكنيشيوم في الوحده في السيزيوم ولا عندك
لا
انتر
بحقنه
اوبريتيف؟
عندي، بس بحقنه قبلها ب6 ساعات عشان يوصل، او ب4 ساعات، لكن البلو داي بحقنها قبلها ب10 دقائق.
يعني انت بتحقنه في الاسم قبلها ب6 ساعات
قبلها ب4 ساعات مثلا،
او 4 ساعات
او في الافاقه مثلا لو هي منتظره لفه ثانيه بلحقنها في الافاقه.
تمام.
لا عشان يوصل حوالي اكتر حوالي 4 ساعات يعني.
بيحضره لك ويطلعه وانت بتحقنه، بتحقنه بري اريولار ولا انترا تيومرال؟
لا بيري اريولار.
بري
مكتوب في الانس ينفع بيري اريولار وينفع سبكوتينيوس او سب ديرمال، ينفع في 3 اماكن يعني.
ثانك يو.
ثانك يو. ثانك يو.
عشان خاطرك بس يا دكتور احمد سيبته اهو، عشان خاطرك عشان المعمل سيبته عشان خاطرك.
حضرتك هتقدم إسراء
اسراء دكتوره حضرتك هتقدم اسراء؟ لا لسه لا انا مش موجود حضرتك.
Our next abstract presented by Dr. Isra Saleh about second line hormonal treatment in breast cancer.
Good morning. I am Isra Salam, assistant lecturer of medical oncology, NCI Cairo University, and a medical oncology specialist at Bahia Hospital. And I am here for presentation of our research regarding efficiency of second-line hormonal treatment in hormone-positive, HER2-negative recurrent and/or metastatic breast cancer. Breast cancer is the most common cancer in women in United States, and second cause cancer death after lung cancer. In Egypt, it is the most common malignancy and second cause of death after liver cancer. Hormone receptor positive HER2 negative breast cancer is the most common molecular subtype. And metastatic breast cancer may be diagnosed as initial presentation, which is known de novo metastatic breast cancer, or develops after treated as early stages. Metastatic breast cancer is incurable, so the goal of treatment is to choose the most suitable drug with least side effects till unacceptable toxicity or disease progression. Types of endocrine treatment act by many methods. First acts by depleting estrogen as aromatase inhibitors, which include non-steroidal and steroidal aromatase inhibitors used in post-menopausal women. And we can deplete estrogen in premenopausal women by ovarian suppression, even medical by LHRH agonist, or oophorectomy or ovarian ablation by radiotherapy. Directly, as another method, directly acting estrogen receptors, selective estrogen modulators as tamoxifen, or selective estrogen downregulators as fulvestrant. Since the endocrine treatment with or without targeted therapy is less toxic than chemotherapy, so it's preferable to be given at hormone-positive metastatic breast cancer. And for a minority of patients with visceral crisis, we can receive chemotherapy to maximize the chance of maximum response. Hormone resistance in breast cancer may be primary resistance or secondary resistance. Primary, which defined by first relapse during the first 2 years of adjuvant endocrine treatment, or progression after 6 months of first-line endocrine treatment. While secondary resistance relapse after at least 2 years of treatment, or within 12 months after completing adjuvant, or progression after more than 6 months of initiating endocrine treatment. And when secondary resistance occur, we can give another type of hormonal treatment. And options that may be given in second-line hormonal treatment may be a single-agent AI or fulvestrant with CDK4/6, or with mTOR inhibitors or PI3K inhibitors, or single-agent tamoxifen, and the choice depends on previous history and tolerance of treatment. And the aim of our study is to evaluate the response and safety of second-line hormonal treatment in hormone receptor positive HER2 negative recurrent or metastatic breast cancer. And the second objectives were progression-free survival and overall survival of the second-line hormonal treatment of recurrent and metastatic breast cancer as a medical oncology experience of National Cancer Institute between January 2015 and December 2019, before the era of using CDK4/6 inhibitor in Egypt. Our study was retrospective, with inclusion criteria included female patients, history with hormone-positive HER2 negative breast cancer, evidence of metastatic or recurrent disease, who received second-line hormonal treatment between January 2015 and December 2019. And the exclusion criteria were our other biological subtypes, early or local advanced breast cancer, who received chemotherapy as second line, or incomplete data records. And we collected demographic features as age, gender, performance status, comorbidities, family history, and menopausal status, treatment characteristics regarding adjuvant, neoadjuvant, ovarian ablation, first-line hormonal treatment, second-line hormonal treatment used in the cases, pathological features regarding TNM stages, number and site of metastasis, histological subtypes regarding and ER positivity, BR positivity, and HER2 score plus KI67, and we assessed also response and survival criteria regarding date of diagnosis, date of starting second-line hormonal treatment, radiological response according to RECIST criteria, and date of stoppage second-line treatment, and date of death or last follow-up. And the study included 116 females with hormone-positive, HER2-negative metastatic breast cancer. 29 of them was metastatic at initial presentation, 24 had isolated local regional recurrence, and 63 patients developed the distant recurrence as after treated as early or locally advanced. All of them received second-line hormonal treatment at Medical Oncology Department, National Cancer Institute in the identified period, with follow-up till June 2022. Our results included that the mean age of our study population was 51.9 years. Half of them was premenopausal and the other half was postmenopausal. 42% of them had comorbidities. Most common comorbidities was hypertension and diabetes, and 28.8% of cases had ER positivity more than 5/8, and 31% BR was more than 5/8. All of them were HER2 negative, but a majority was HER2 score 0. Regarding the site of metastasis, 39.7% had bone-only metastasis, 34.5% had visceral metastasis, and the rest of patients included both visceral and bone-only metastasis. Second-line hormonal used in our study, unfortunately, 4 cases only had tamoxifen. Fulvestrant included 68 cases, and steroidal and non-steroidal aromatase inhibitors was 44, non-steroidal was 13, and steroidal was 31. Our results. Response rate, which was identified as the cases who achieved CR or BR on RECIST criteria after 3 months. Regarding fulvestrant, it achieved 26.5% response rate versus 9.7 with steroidal AI, and 15.4 was non-steroidal AI. As regards the clinical benefit rate, which was identified as cases who achieved CR, PR, or stationary disease on RECIST criteria after 6 months evaluation, it was 61.8 with fulvestrant. With steroidal AI, it was 64.5%, and with non-steroidal, it was 76.9. As regards side effects, all side effects of hormonal treatment was mild and tolerable, and the majority of them was bone aches, fatigue, and muscle cramps. And low percentage had hot flashes. As regards overall survival with second-line hormonal treatment at 5 years, it was 86.8, and at 10 years, it was 54%. 5-year overall survival was 90.4% versus 91.7 versus 76.4 with fulvestrant, anastrozole, and exemestane respectively. And anastrozole showed 153 months overall survival versus 102 months with exemestane. As regards 3 years progression-free survival with second-line hormonal treatment, it was 22.3%. 3 years progression-free survival, it was 19.8 versus 20.5 versus 17.6 versus 25 in fulvestrant, anastrozole, exemestane, and tamoxifen respectively. 3 years progression-free survival was 20.5 versus 17.6 in anastrozole and exemestane. As conclusion, second-line hormonal treatment can be safe and efficient line of treatment in hormone-positive, HER2-negative metastatic breast cancer and or recurrent instead of chemotherapy, even in absence of CDK4/6 inhibitor availability. There was no statistically significant difference in endocrinal treatment as regard fulvestrant AI or tamoxifen, which were used as second line as regard response rate, clinical benefit rate, progression-free survival, overall survival with tolerable side effects. And our recommendation necessitated large popular study to confirm or negate our results, strict follow-up at our clinic with continuous effort toward treatment and management of treatment adverse effects. And thanks to Egyptian campaign to availability of CDK4/6 inhibitors from October 22 at NCI to augment our study in the next coming years. And thank you.
ازيك يا اسراء؟
الحمد لله.
طبعا خدت شويه زياده من وقت يا اسراء، بعد كده ايه تحسني البرفورمانس
ماشي.
بتاعك في البرزنتيشن.
ماشي.
انت قلت ان ده سكند لاين هرمون صح؟ في اول حاجه في الانكلوجن كرايتيريا انت كاتبه انها ميتاستاتيك بريست كانسر. ازاي بقى هتبقى ميتاستاتيك بريست كانسر؟ اول برزنتيشن بتاعك هيبقى ميتاستاتيك وهتديله ازاي سكند؟
لا مش فاهمه السؤال. السؤال
لا
ايه؟
انت كاتبه في البرزنتيشن يا اسراء على ما اتذكر اول حاجه ميتاستاتيك بريست كانسر.
ماشي.
طيب انت ما هو فيرست برزنتيشن دخل عندك ميتاستاتيك ولا قصدك ايه؟
لا هم الميتاستاتيك بريست كانسر اللي ريسيفد هرمونال تريتمنت بعد الفيرست لاين هرمونال.
مش واضحه في الكلمه اللي انت كاتباها يا اسراء.
ماشي.
بصراحه انت كاتبه اول برزنتيشن من ضمن كده يعني انت دخلت ترايل وهي ميتاستاتيك. ولا يا دكتور احمد دخلت؟ لا انت ما لازم معاك في الترايل صح كده؟ تاني حاجه يا اسراء انت مش حددتي ده بري مينوبوزال ولا بوست مينوبوزال ولا ايه، انت كتبتي كل الكلام وقلتي كل حاجه ما عدا انت المفروض هتسلكتي البيشنت اللي هي بريست مينوبوزال خدت ايه واللي بري مينوبوزال خدت ايه. تمام كده؟ وبعدين انت برضو كنت كاتبه اوبشن واحنا عندنا في بهيه راديو ثيرابي. طب ليه اوفيريان كاستريشن ممكن يتعمل بالراديو ثيرابي ما جبتيش له دور خالص؟ تمام؟ كان المفروض تقسمي اللي هو بري وبوست مينوبوز.
اوكي
ماشي. ما اعرفش تسالي عشان بنتك يعني حد يسال؟
خلاص
شكرا يا اسراء.
شكرا.
Next speaker, Dr. Ala Zidane, Assistant Lecturer, Department of Radiology, South Egypt Cancer Institute, Asyut University. Is contrast enhanced spectral mammography a good imaging modality for predicting the accurate breast tumor size?
محمد جمال ده سيرجري. في محمد جمال الاول قبل محمد جمال موجود. محمد جمال
لسه ما جاش. طب بصوا
طب حد من اللي موجود له ابستراكت؟
دكتور محمد زعقوق.
طب اتفضلي يا دكتور.
الراجل المحترم ده
The next.
السنه اللي فاتت.
محمد
انت كسبت السنه اللي فاتت يا محمد؟ مش انت اللي كسبت السنه اللي فاتت؟ انا فاكرك كويس.
Now we will listen to Dr. Mohammed Zaouk about genetic variants, pathological features and outcome of Asian hereditary breast and ovarian cancer results from a large UK regional reference genetics laboratory.
Mohammed Zaouk, lecturer of cancer pathology, National Cancer Institute, and consultant pathologist at Bahia Breast Cancer Center. We are talking today about germline mutations and pathological features of breast and female genital cancers in increased risk patients of Asian origin.
علي صوتك من فضلك يا دكتور، علي صوتك.
شكرا. Germline mutations and pathological features of breast and female genital cancers in increased risk patients of Asian origin. Patients of non-Caucasian and Asian ancestry comprise about 10% of the population in the West Midlands, which is the second largest county in the UK. Breast and ovarian cancers in non-Caucasian women tended to present at an earlier age with more aggressive disease. Little is known about the genetic profile of hereditary breast and ovarian cancer patients of non-Caucasian ancestry, which represent nearly half of the world population. There is paucity of data on the histological features of the cancers that develop in these patients. In our work, we aimed to analyze the patient genetics and pathological features of those cancers. This information will be useful for risk prediction and applying prevention strategies in affected individuals. We have studied 5,618 patients were deemed clinically of increased risk and were genetically tested between 2006 and 2018 at a large regional reference genetics laboratory in Birmingham. The ethnicity of these 5,600 were nearly 5,000 were of the British white ancestry, about 300 of unstated, and the studied population were 164 of Asian ancestry, which were subclassified mostly to Pakistani and Bangladesh ancestries. All patients were screened for mutations of BRCA1 and 2, and a subset were also tested for PALB2, RAD51D, and others as per the clinical guidelines. As from the 2006 to 2018, the NCCN guidelines of the UK, which are guiding who are the patients who are going to be tested, the threshold actually has decreased from 20% to 10%. So large number of patients or their families have been tested. Histopathological and clinical data from the referring hospitals were collected and correlated with the genetic results and patients' outcome. I'm sorry, it's not the NCCN, it's the NICE. 51 variants had been detected, 30 pathogenic and 21 non-pathogenic. As the genetic mutations are subclassified into pathogenic, non-pathogenic, and the variants of uncertain significance. These 51 variants were identified in 46 patients out of the tested 164. 28%, this means that nearly or more than 1/4 of the patients had genetic mutations. The 46 patients, 41 of them had single variants, and 5 of them had dual variants. These variants were detected in BRCA1, BRCA2, BRIP1, PALB2, and RAD51D. This is distribution of the detected variants. We can find here in the BRCA1, 26 mutations, BRCA2, 22, 1 in PALB2, 1 in BRIP1, and 1 in RAD51D. In the BRCA1, most of the mutations were pathogenic, 21 out of the 26. In the BRCA2, most of the variants were of variants of uncertain significance, 12 out of the 22, and the PALB2 and the BRIP1 it's just one, and it was pathogenic, and the RAD51D was not VUS. These percentage, just to clarify, incidence of pathogenic variants in patients tested. The BRCA1, 164 patients were tested for BRCA1, 21 of them had pathogenic mutations, this representing nearly 13%. In the BRCA2, 7 patients out of the 164 had pathogenic mutations, representing nearly 4%. The BRIP1, only 15 patients were tested, and 1 of them had a pathogenic mutation. This is nearly 7%. And the PALB2, which was tested in 65 patients. Only one of them had the pathogenic mutation, representing 1.5% of the patients. The important findings: 2 extremely uncommon pathogenic BRCA1 variants were repeated in 2 unrelated cases. 2 cases were negative for BRCA1 and 2 mutations, but later on were tested positive for BRIP1 and RAD51D. The 4 non-pathogenic variants which were detected in BRCA1 and the 3 BRCA2 were initially classified as VUS, then were later reclassified as non-pathogenic. This is distribution of the 30 cases. 23 had breast cancer, 4 had gynecological cancers, 2 had combined cancer, 1 of them had ovarian and breast cancers, and 1 of them had ovarian and cervical cancer. And 1 of the patients had GI cancer, and 1 of the related family members had no cancer. These figures represent the breast cancer's grade and type according to the detected mutations. To the left of each figure, we will find the pathogenic. For example, here, we have the pathogenic variant and the non-pathogenic. In the pathogenic variant, nearly 90% of the patients had grade 3 cancers, compared to only 50% in the non-pathogenic. According to the molecular type, the triple negative constituted about 40%, and the non-pathogenic
Muhammad,
variant
you passed
only-
your time. You passed your time, خلاص.
Okay.
10 minutes خلصوا خلاص. And you have 1 minute to complete. You have 1 minute. You have 1 minute to finish.
Okay, just 1 more minute. Okay. Okay, to conclude, the 4 non-pathogenic variants were originally classified as VUS, but with later reclassification were defined as non-pathogenic, and this implies the importance of complete analysis and reclassification of VUS variants, which would result in precisely classifying them as either pathogenic or non-pathogenic. Detected BRCA1 and 2 pathogenic variants in non-Caucasian patients are higher than those reported in white Caucasian population. Other variants were identified in BRIP1, PALP2, and RAD51D, and this highlights the importance of wider panel testing to detect variants in other susceptibility genes. And lastly, patients at increased risk of hereditary breast ovarian cancer presented with higher grade breast cancer at younger age with larger proportions of the unfavorable triple negative phenotype. This highlights the importance of further studies into women of diverse ethnicities with hereditary breast ovarian cancer are required to refine risk assessment, counseling, and management of those patients. Thank you.
شكرا دكتور محمد. بس أنا عاوزة أسأل سؤال، ليه ما حاولناش نعمل الاستادي دي على الإيجيبشن بوبوليشن؟
محتاجة الجيناتيك، يعني هم هناك الجيناتيك كونسلنج او كده ده اوريدي استابليشد، وطبعا مكلف جدا ومحتاج فولو اب داتا. يعني دول عيانين ال 5000 دول من 2006 to 2018. وكمان زي ما قلت اللي هو ال NICE بيقلل الثريشولد اللي هو بيختار على اساسه العيانين من 20% لما يبقى في increased risk ل 10%. فهو mainly ان انا محتاج follow up للبيشنتس ومحتاج السيرفيس اللي هي مكلفه جدا. يعني هم بداوا بسانكر سيكونسنج ومن 2014 completely shifted للnext generation sequencing which is much more expensive.
شكرا دكتور محمد.
علا مجدي موجودة؟ موجودة علا؟
دكتورة علا مجدي, lecturer of diagnostic and interventional radiology, National Cancer Institute, Cairo University. Interval breast cancer radiological surveillance in screening Egyptian population.
Interval breast cancer, radiological surveillance and screening Egyptian population. I'm Ala Magdi, lecturer of radiology in National Cancer Institute and radiology consultant in at Bahia Hospital. Interval breast cancer is a term given to cancers detected or presenting within 12 months after a mammographic screening in which findings are considered normal. This is divided into true negative interval cancer that no signs of disease could be detected on the previous screening mammogram. The lesion is new. While retrospectively visible interval cancer, missed cancers, can relate it to tumor factors, provider factors, patient factors, and technical failure factors. The tumor factors as lesions interpreted as benign lesions, benign mimic. This include lesions that proved to be malignant showed benign morphological characteristics on the previous mammogram, especially well-circumscribed masses. Calcific foci not reaching the pathological descriptors. Other subtle changes includes areas of architectural distortion, focal asymmetrical densities, masked carcinoma by another eye-catching benign lesion, or slowly growing, such as DCIS with stationary course. Provider factors, interpretive error on part of reader, number of things can affect how something is perceived and interpreted, such as inadequate training, inexperience, subtle indicators of malignancy, exhaustion, poor viewing conditions, and distraction. The second item, single reader. As a second reader would have discovered the lesion. Patient factors such as dense breast parenchyma, hiding the lesion, and technical failure factor, a technically poor image hampered the reader to discover the abnormality in theory. Suboptimal images will not be submitted for interpretation, and if they are, should not be read. The aim of the study is to relate the risk factors for development of the interval breast cancer, such as breast density and positive family history of breast cancer, highlight the causes of missed breast cancer in order to overcome it in the future radiological interpretation. A total of 74,546 screening mammographic examinations were performed in Bahia Foundation for Early Detection and Treatment of Breast Cancer in the period between 2015 and 2021, with about 844 pathologically proved malignant cases. We included 185 proven breast carcinomas, 88 were true interval breast cancer, and 97 were missed on mammography and detected later on. The cases were subjected to digital mammography, complementary ultrasound, contrast-enhanced mammography, or MRI in some cases. Results: the mean age of the patients was 53.5 years. The overall breast cancer detection rate was 11 per 1,000 women. The 185 interval cancers were present at a rate of 3.8 per 1,000 women. True negative interval breast cancer, where 88 cancers were not present at retrospect on screening mammogram, in which the recorded positive family history found in about 35%. 17 cases present with benign findings, benign mimics, and 80 cancers were missed cancers. Analysis of the cause of missed carcinoma revealed patient-related, tumor-related, or provider-related. No missed cancers due to technical errors in our study. Tumor factors were the most commonly encountered, about 94.5%, and provider factor, 0.8%. The least encountered were the patient factors, 24.7%. Case 1, a 59-year-old female, baseline mammogram reported as BI-RADS1. Next annual mammography shows upper outer dense non-circumscribed mass at the right breast, which is proved pathologically to be invasive duct carcinoma. Through interval breast cancer, the lesion is new. Case 2, 49-year-old female with positive family history under regular annual mammography. Baseline mammography reported as fibrocystic changes by BI-RADS2. 9 months later, the patient felt a palpable lump, which, revealed the mucinous carcinoma grade 2 by pathology, and also the lesion is new. It wasn't present in the previous mammogram. Case 3, a 64-year-old female coming for her regular annual screening, showing benign calcifications and popcorn calcification of involuting fibroadenoma, reported as BI-RADS2. The next follow-up shows newly appreciated lesion in the lower inner quadrant, which was present in the previous mammogram as a smaller nodule, proved by pathology to be invasive duct carcinoma grade 2, and this is associated microcalcification seen at the present study. Missed cancer due to benign mimic nodule. 50-year-old lady, her regular annual screening mammography revealed non-circumscribed dense mass at the upper outer quadrant, which was present as subtle focal asymmetry in the previous annual mammogram. Biopsy revealed invasive duct carcinoma grade 2. Missed carcinoma due to subtle mammographic changes also. Conclusion, even though mammography is the gold standard for identifying early breast cancer, many breast cancers may miss due to different etiology. The radiologist should thoroughly evaluate the screening views and order diagnostic views and complementary ultrasound as well, paying particular attention to small asymmetries and microcalcification. Palpable lesions and clinical data must be further examined with ultrasound and contrast imaging if necessary. Always check for minor increases in lesion size by comparing the current images with several previous examinations whenever possible. After discovering one pathology, search for more lesions. Thank you.
هو يا دكتورة زي ما انت قلتي في الكونكلوجن ان كل البيش انت ما كنتيش بتعملي ده بقى ان انت تشوفيهم سونار، يعني احنا دلوقتي بقينا بنشتغل سونو مامو على طول. فهل دول في سكريننج؟
لا، هي السكريننج بيشنتس بنبتدي بالماموجرافي، ودلوقتي بقى في كمان توموسينثيسيس، بس احنا مش كل البيشنتس ممكن يدخلوا الترا ساوند لو السكريننج از باي-RADS1، يعني زي الفيرست كيس ACRA ما فيش اي ليجنز، ما فيش كومبلينت، ما فيش اي حاجه باي اكزامينيشن،
ما فيش بالبابل ماسز، ما فيش حاجه
بالظبط.
ثانك يو.
ليا سؤال ليكي برضه يا دكتوره علا. انت حضرتك قلت لنا في الحالات التايم انترفال، انت قلتي في حالات طلعت بعد سنه، في حالات بعد 9، كان المفروض تقوليها لنا في الريزلتس معظم حالاتك شفتيها تاني سكند لوك بعد قد ايه؟ أوكي. يعني حالاتك ايه كانت من كام لكام؟ لا، حالاتي كانت اغلبها انيوال، الا لو البيشنت فيلت something قبل ما السنه تعدي. يعني برضه تاني الكيس ان هي البيشنت فيلت لامب، فعشان كده جت افتر 9 months.
انت اشتغلتي على حالات كتير قوي، يعني عدد كبير قوي، وده هايل. كل الحالات دول انت عملتي لهم الفرق كان سنه مش اكتر من سنه، يعني لان لو اكتر من سنه تبقى المشكله مش مشكله تكنيك، هي المشكله ان هو ده الناتشورال كورس اوف ذا ديزيز.
لا هم كلهم سنه واحده.
شكرا جزيلا.
دكتوره علا معلش سؤال، كيس 1 في البريفيس ماموجرام كان في ليجن موجود، بس كان في ليجن موجود بس مستخبي ببيكتوراليس ميجر. كيس نمبر 2 انت كاتبه عليها بايراتس 2 بس هي اكشلي بايرات 3 وهي فيها a lot of micro فيها bunch of micro classification بس هي micro classifications كتير قوي. ف this patient should have been investigated further.
هي further examined by ultrasound لان هي البايرادز هي fibrocystic ومعاها involuting fibroadenoma لكن هي البايراد
لا سيب من الفايبرادينوما في اللور بارت في مليانه كالسيفيكيشنز يعني ما كانش تروح دي كان لازم تبقى بكونتراست ماموجرافي او بام ار اي.
ما هي تعمل لها التراساوند هي ما
الالتراساوند مش كفايه. ام ار اي في المايكرو
ما احنا بنعترف ان في ليجنز كانوا مست فعلا كانت
بس كيس 1 بالتاكيد كان في ليجن موجود واضحه جدا.
وانا اعتراضي ان انا كجراح لما ما بطلبش ماموجرافي، انا بقول بايلاترال ماموجرافي ويز كومبلمنتري الترا ساوند. في ميست بيشنت كتير بتروح التشاينيز ريكومنديشن فور evaluation of the patient or screening of the patient by sonography مش ماموجرافي لانهم لقوا ان الدنسيتي اوف بريست عندهم مش بتبان بالماموجرافي. يبقى اذا دنس بريست مش هيبان بالماموجرافي.
صح.
ودي لازم من الاول تكون متاخده في التوصيات بتاعه السكريننج.
احنا باي ديفينيشن ان السكريننج بيبقى ماموجرافي واف نيدد بيبقى التراساوند ساعتها بيبقى اسمها دايجنوستيك بقى احنا ده مش السكريننج. لكن في حالات الدنس بريست او يونجر ايج وذ بوزيتيف فاميلي هيستوري الالتراساوند بيبقى سكريننج تول هو وساعات الام ار اي كمان. تمام.
محمد جمال موجود؟ لا محمد.
شكرا.
محمد جمال Associated Consultant of Breast Surgery بهية Foundation Associated Lecturer of Surgical Oncology NCI. He will talk about immediate direct to implant breast reconstruction in Egypt.
البوينتر بس بدوس عليه بيتحرك. مش لازم مش هحتاج بوينتر مش هحتاج. Okay. As it's well known that about up to 40% of women diagnosed with breast cancer will require mastectomy each year. Since nipple sparing and skin sparing mastectomy are proven to be oncologically safe, implant-based reconstruction has increased and become the most reconstructive procedure performed worldwide. Traditionally, there was a two-stage approach, an expander then an implant sequence. However, with the introduction of biological and synthetic mesh allowed for the creation of a subpectoral or a prepectoral bucket which allowed for DTI. Aim of our study is to evaluate the complication and safety of DTI in addition to assessment of patient satisfaction using BreastCube. We conducted this study on 66 patients in National Cancer Institute from December 2019 to December 2022. We included all patient candidates for nipple sparing or skin sparing mastectomy, whether to treat cancer or for a risk reducing. We start our pre-operative assessment by taking a proper full history, especially the smoking habits, the diabetic comorbidity, the history of radiation therapy. And we start by examining the breast skin quality, elasticity, cup size, ptosis, the nipple areolar complex, any changes in the skin. Then we started our markings at the same day of surgery by marking the midline, the breast meridian, the upper pole, the inframammary fold, the lateral contour of the breast. In this case, we used an infralateral incision for a nipple sparing mastectomy. This is a case of skin sparing by elliptical incision with adjustment of the inframammary fold. This is the implant, this is the mesh we used in this study. We use 3 different types of techniques, either subpectoral, prepectoral, or dermal sling. In the subpectoral, we released the pectoralis major muscle, and we completed the bucket by suturing the mesh to the muscle and to the inframammary fold. While in the prepectoral, the implant was wrapped completely around the mesh, and we put it in a prepectoral position. In dermal sling cases in huge breast, we sutured the dermal sling to the released border of pectoralis major, or we sutured the mesh to the dermal sling, then to the anterior surface of pectoralis major. About 66 patients were included in this study with a median follow-up of 15 months. Almost 1/3 had a positive family history for breast cancer. 2 patients had prophylactic surgery after testing BRCA1 positive. We have done about 41 skin sparing, 17 nipple sparing, 12 skin reducing. We used the Ultra Pro mesh in most of our cases. We started our experience by using the submuscular technique, followed by shifting to a pre-pectoral reconstruction. Then we assessed the complication by dividing them into 2 groups, the early group and the late group. This division is mainly to assess the radiotherapy effect over this reconstruction technique and to assess the feasibility of the Ultra Pro mesh. The most common complication in the early group was full thickness mastectomy skin necrosis, an infection which resulted in 7 implants to be removed. The other minor complications were treated conservatively by antibiotic repeated dressings. In the late complication group, which is after 6 months of the operation, we assessed the capsular contracture, which was the most common complication, about 21%. 2 implants were extruded after radiation therapy. 1 developed radionecrotic ulcer. Then we assessed the risk factors for complication. We have found that the lateral incision plus superior circumareal extension was associated with higher complication. Prolonged drain removal associated with higher complication. However, the site of the implant, the use of the mesh was not as significant factors for complications. In addition, we assessed the adjuvant treatment over this reconstruction. We have found that there is a 3.5 risk increase in post-radiotherapy and increased risk of complication after chemotherapy, whether adjuvant or neoadjuvant. We have found that the radiotherapy increased the capsular contracture to 27% and resulted in high rate of implant removal. Then we assessed the satisfaction using BreastQ. We obtained average aesthetic good results. However, these figures decreased in the complicated cases. Then we assessed the technique drawback between the prepectoral and the subpectoral. We found no statistical significance regarding the rate of complication or capsular contracture. The only difference is that the upper pull deformity is seen more in the prepectoral technique, while the animation deformity is more in the subpectoral technique. Here is some cases. This is a case of upper inner quadrant triple negative 23 years old female after neoadjuvant chemotherapy. We have done in this 2 weeks post-operative, 3 months after the operation. This is after radiation therapy. The skin changes resolved spontaneously after 2 months. However, this is a good aesthetic result. This is subpectoral, an example of subpectoral using lateral incision. This is a prepectoral, skin sparing. Here is we wrap the mesh around the implant and we put it in a prepectoral position. This is an example of prepectoral also. We see the patient intraoperative and we put the implant and we use the mesh as mechanical support for the implant position. This is prepectoral example. This is areola sparing, also prepectoral. This is prepectoral with contralateral symmetrization reduction technique. In this case, we didn't use the mesh, and you can see that there's lateral shift of the implant because the mesh produces only mechanical support for the implant position. In huge breast, we used the dermal sling technique. In this case, we have done left therapeutic reduction mammoplasty and right mastectomy with DTI using the dermal sling technique and nipple areola complex free graft. Sometimes we preserve the nipple areola complex using pedicle technique. In this case, this is BRCA1 positive case. We have done bilateral mastectomy, nipple sparing, with the dermal sling attached to the Ultra Pro mesh to the anterior surface of pectoralis major, with good aesthetic result. But nothing without complications. So we had a skin flap necrosis, resulted in implant loss. This is post-radiotherapy effect. Some cases of skin flap necrosis were managed by rotational flap. This is pictures of capsular contracture. Can I have one more minute? لا لسه sorry. Okay, this is a case of red breast syndrome after excluding an infectious cause treated by antihistaminics and corticosteroids. This is a post-radiotherapy necrotic ulcer. Summary and conclusion: direct to implant reconstruction in probably selected patients offer excellent outcome and patient satisfaction. The complication rate is low, improves with the experience of the surgeon. It can avoid multiple tissue expansion seen with tissue expanders and save the patient for prolonged operative time, post-operative pain seen with autologous flaps. About 29 patients underwent prepectoral, while 41 patients underwent subpectoral reconstruction. There was no statistical significance between the rate of complication or capsular contracture or breast Q, while only the upper pole deformity was more in the prepectoral group, which is easily corrected by fat grafting. So we recommend using the prepectoral approach. We have experienced superior clinical and functional outcome with minimal pain and less animation deformity. Ultra Pro Mesh is a cost-effective alternative to ADM and more other expensive synthetic mesh. Mastectomy skin flap necrosis was the most common complication, so the use of laser-assisted endocyanine green test could be a valuable tool, and we have to assess skin flap vascularity intraoperative before and after insertion of the implant. Drains should be removed as soon as possible because it's associated with higher complication rate. Radiotherapy is an important risk factor for complication, so patients known to receive radiotherapy should be thoroughly counseled for possible complication. Chemotherapy, whether adjuvant or neoadjuvant, is associated with higher risk of complication in our study. Further studies is needed to justify this finding. Thank you.
شكرا دكتور محمد، شغل جميل. بس انا عايز اوضح الفكره. انت عايز تقول ان احنا قبل كده كنا بنشتغل ان تو ستيبس، بنحط تيشو اكسباندر وبعد كده بنحط الامبلانت. دلوقتي شايفين الامبلانت ان وان ستيب مور سيف.
بالظبط.
ده كلام جميل.
تمام.
والمفروض تكون كلمه واضحه في الاول. الحاجه الثانيه لما بنشتغل احنا عندنا ديبيت بري بيكتورال ولا سب بيكتورال. فلما يكون في ديبيت لغايه دلوقتي الناس مش قادره تجزمه، لما تعمل استادي حاول تخلي عندك ستاندردايزيشن اوف مانوفر علشان ما يبقاش انا باخد فاينل ريزلت وعندي حاجتين شغال فيهم، حالات سب بيكتورال وحالات بري بيكتورال. يو شود ستاندرايز يور مانوفر. انا هشتغل بري بيكتورال وهستخدم كل مره المش، هستخدم كل مره ADM علشان اخد ريزلت تبقى ريلايبل ريزلت واعتمد عليها واعمل بيها ريكومنديشن ان البري بيكتورال از مور سيف مور كوزموتيك، الاستيك اوت كم احسن. ان لما استخدم المش بتساوي الADM، المش اللي هي ب $20 تساوي الADM اللي ب $2000، فعلشان يبقى عندي ريزلت في الاخر بقول هي دي الريزلت. فهمت قصدي؟
تمام. احنا فعلا عملنا كده يا فندم. احنا بدانا بالسب بيكتورال في الاول، وبدانا كان عندنا تايلوب وعندنا الترا برو، استخدمنا في 4 حالات تايلوب ماش. بس عشان الماش دي بقت اكسبنسيف قوي، واحنا بدانا في وقت الكورونا فما كانش فيه ولا امبلانت ولا مش متاحه اصلا ان احنا نجيبهم حتى من بره، فاستخدمنا الالترا برو ماش بيزد على استادي حصلت في المجر، ولقوا منها ريزلتس كويسه ولقيناها ان هي افوردبل للبيشنتس بتوعنا. بعد ما بقينا مرتاحين بالسب بيكتورال بدانا نشفت الحالات كلها لبري بيكتورال بنفس التكنيك بنفس كل حاجه. هي اللي فرقت ان احنا ما بين السب بيكتورال والبري بيكتورال، وعملنا في الاخر كومباريزن بكل البوينتس اللي ممكن تفرق ما بينهم، يعني which technique is better، ولقينا ما فيش اي فرق خالص ما عدا ان الانيميشن ديفورميتي اكتر في السب بيكتورال. فهو فعلا ليه superior outcomes سواء كلينيكال او فانكشنال.
محمد بس سؤال واحد وتجاوبنا يعني في كلمتين. الراديو ثيرابي when we start radiotherapy after silicone implant or after flap in the time of radiotherapy after your operation.
زي اي تايم للكونزرفتيف او للماستكتومي once الوندز بقت هيل she can receive radiotherapy.
الفلاب زي السيليكون ولا في اختلاف؟
زي ايه يا فندم؟
سيليكون امبلانت.
زي ايه؟
السيليكون
هي الفكره كلها، هو مش هتفرق التايمنج بعد الانسرشن اوف ذا سيليكون قد ايه، لكن هو كده وكده بيحصل كابسولار كونتراكشر في about 27% اوف كيسز.
لكن انت ما عندكش تايم معين نبدا بعده راديوثيرابي؟
لا ما هو مش يعني انا قصدي ان هي مش هتفرق بدانا امتى
راديوثيرابي. ازاي الفلاب ده بيبقى له بلاد فلو هي انا كراديوثيرابيست مثلا هديله امتى الراديوثيرابي؟ ده سؤال مهم جدا. نعم 6 شهور. ماشي، انا بتكلم هو افرض انا عاوز اديله هرمون وهديله راديوثيرابي، افرض هي ايرلي ستيج زي ما هو عمل بروفلاكتيك ماستكتوم مع الكونترالاترال بريست، امتى؟ ما هو لازم يبقى عندي تايم.
هو موستلي يا بيه لما بيحصل هيلينج بعد شهر مثلا ماكسيموم، يعني ما فيش مشكله بعد شهر ان احنا نبدا حتى راديو.
طب وبقراها يا محمد
لكن مش في الليترشر مش عاملين تايمنج ليها. اوكي.
بالظبط كده.
انت لما بتبقى عامل بلاستيك بريست سيرجري وعندك ديد سبيس وبتروح مفيش شويه سروما بيرجحوا لك يقول لك لا استنى مش هبدا راديوثيرابي غير لما الدنيا تسبسايد، فاتليست 6 ويكس علشان تقدر تقول انا هبدا راديوثيرابي وانت عندك امبلانت وحاطط ديش في فربط، فانت وارد يحصل في كومبليكيشن.
تمام. لا ده سؤال لازم.
هو فعلا معظم العيانين بيقعدوا
يرجع لك الحاله ويقول لك ابدا امتى راديوثيرابي، وحضرتك عشان اكسبرتايز مور زين يعني سرت بالظبط. ما هو المشكله في كده، احنا عاوزين يبقى في ام دي تي، امتى ابدا راديوثيرابي. الحته ديت بصراحه بتقرقنا عشان البيشنت ده ممكن زي ما الدكتور ياخد 6 شهور فعلا كيموثيرابي، في حالات ما بتاخدش، فلازم ابدا مثلا هرمون وراديوثيرابي. بالظبط، هو 6 مانثs 7 مانثs يعني. شكرا يا محمد. شكرا يا حبيبي.
دكتورة ريهام. She will talk about the predictive value of malignancy in breast masses, BI-RADS 3 and 4, using ultrasound elastography and MR diffusion weighted imaging.
حول منين حول السلايد. لا انا عايزه بس النكست. ده النكست. طيب اوكي. Good morning everybody. My name is Riham Rifai, lecturer of Radio Diagnosis, Cairo University, and consultant of Breast Imaging Bahia Foundation. It's my pleasure to share with you our study titled The Predictive Value of Malignancy in Breast Masses, BI-RADS 3 and 4, using ultrasound elastography and MR diffusion weighted imaging. Bismillah ar-Rahman ar-Rahim. Let's start with a brief introduction. Breast cancer is the most common malignancy among females in the world. Breast ultrasound elastography provides a non-invasive evaluation of the lesional stiffness. Diffusion-weighted imaging is reported to be highly sensitive for evaluation of breast cancer and differentiating benign from malignant tumors. Our goal: to evaluate the ability of ultrasound elastography and MR diffusion to predict malignancy in breast masses categorized as BI-RADS 3 and 4. Regarding ultrasound elastography, it's classified into qualitative method and a quantitative method. Regarding the qualitative assessment, it depends on the color map, which is generally less accurate, starting from the blue color denoting soft tissue elasticity up to the red color denoting hard tissue elasticity. While the quantitative assessment depends on the measurement of the Emax and E ratio. Emax, which is the maximum elasticity of the tissue, and E ratio, which is the ratio between the elasticity of the region and the elasticity of the surrounding parenchyma. Regarding MR diffusion, it measures the random movement of water molecules, which is called the Brownian movement. Malignant tumors tend to show a high cellular density, while the benign lesions tend to have less cellularity. Regarding MR diffusion, it's also classified into a qualitative assessment and a quantitative assessment. In general, malignant tumors show restricted diffusion and ADC value less than 1. Our patients and methods. This study included 66 patients, BI-RADS 3 and 4. All patients underwent sonomammography, shear wave elastography, contrast-enhanced MRI, and MRI diffusion. Regarding our results, in our study, the cutoff values to differentiate benign from malignant lesions were Emax 65 kilopascal, E ratio 4.5, and ADC value 1.2. Upon correlating our results with histopathological results, contrast-enhanced MRI showed the highest diagnostic indices, while the Emax showed the highest sensitivity, and ADC value showed the highest specificity. Let's view some cases. Case number 1, female patient, 55 years old, presented with a left breast lump. Conventional ultrasound revealed left upper outer quadrant hypoechoic irregular shaped lesion categorized as Pirace 4. Shear wave elastography showed a hard lesion, Emax of 200, E ratio of 7.3, so it's considered suspicious by shear wave elastography. MRI showed REM uptake, restricted diffusion, and a malignant ADC value of 1.1, so also it's considered suspicious by MRI. The NET diagnosis, invasive ductal carcinoma. So in this case, both shear wave elastography and MRI diffusion revealed true positive results. Case number 2, female patient, 39 years old, presented with a left breast lump. Conventional ultrasound revealed left upper outer quadrant hypoechoic speculated lesion categorized as Pirace 4. Shear wave elastography showed almost hard lesion with a nearby focus not detected by the conventional ultrasound. Emax 120, E ratio 13, so it's considered suspicious by shear wave elastography. MRI showed heterogeneous uptake while the diffusion wasn't restricted and ADC value was of benign value. Final diagnosis, invasive lobular carcinoma. So in this case, diffusion MRI assessment revealed false negative result. Case number 3, female patient, 44 years old, presented with a left breast lump with a strong family history. Conventional ultrasound, left upper outer quadrant, well circumscribed, oval-shaped, hypoechoic lesion categorized as Pirace 3. Shear wave elastography showed about 50% of the lesion hard areas, Emax of 80, E ratio of 55, so it's considered suspicious by shear wave. MRI showed no uptake, non-restricted diffusion, and a benign ADC value. Final diagnosis, fibroadenoma, so shear wave elastography revealed false positive results. The last case, female patient, 63 years old, presented with a right breast lump, conventional ultrasound, right lower inner quadrant, complex cystic lesion, Pirace 4. Shear wave elastography showed, although more than 50% of the lesion show low elasticity, yet hardening of the surrounding parenchyma raised suspicion of an infiltrative process. MRI showed REM uptake, diffusion restriction, and a benign ADC value, so final diagnosis was invasive ductal carcinoma, and ADC value reviewed a false negative result. To conclude, contrast-enhanced MRI has the upper hand in diagnosis of breast cancer owing to its morphological and functional assessment, yet ultrasound, elastography, and MR diffusion narrow the false results of sonomammography and MRI. Alhamdulillah. Shukran.
يا دكتورة حضرتك كل الناس السبيكرز اللي اتكلموا معظمهم على البريست وهاو تو ديتكت او اير ديتكشن اوف ذا بريست. طيب هو ناس قالت المامو سونار مفيد في حاجه والام ار اي مفيد في حاجه. انا كاونكولوجيست في انديكيشن معينه بطلبها للام ار اي في البريست بس، تمام؟ وفي حاجات بطلبها في اي حاله تانية. انت رايك امتى نطلب الام ار اي اكيد، وامتى نطلب السونار او الماموجراف في حالات تانية؟
ان جنرال يعني حضرتك تقصد؟ احنا الام ار اي ده بيبقى حاجه زي حلال المشاكل. يعني انا دلوقتي لو المامو والسونار محتاج بعد ما عملتهم مش واثقه من التشخيص، حاسه محتاجه فيردر اسسمنت، ابدا بقى بروسيد لحاجات ثانيه زي
ايه هي الحالات بقى يعني عاوزين؟
مثلا في حالات الدنس بريست، في حالات سبيشال لو عندها بوست فاميلي هيستوري، عيانه مثلا انفيسيف لابيلار كارسينوما مشهور فيها البايلاتراليتي والمالتي سنتريسيتي، عيانه مثلا كانت خدت نايو ادجفنت وعايزه اسس بقى بوست، بس ده محتاجه اكون عامله قبلها بيزك قبل التريتمنت. الام ار اي ممكن برضو يستخدم في السكريننج في حالات اللي هم الهاي ريسك بيشنتس سبيشالي مع الدنس بريست. ممكن ما اقدرش اعتمد بس على مامو والسونار، سبيشالي ان في حاجات بتبقى ممكن في الانترفال ما تظهرليش، يعني تظهر لي مثلا انهانسمنت في الام ار، لكن في المامو والسونار ممكن ما يظهرليش فيها اي سسبيشس ليجنز يعني.
طب بوست الراديو ثيرابي بنطلب ام ار اي ولا المامو ولا السونار؟
بوست راديو ثيرابي اعتقد according للشكوى بتاعت العيان، يعني مثلا لو العيانه جايه في لامب محسوسه مثلا بعد الراديو، اصل الراديو ثيرابي
بوست الراديو ثيرابي ام ار اي، ما فيش بنعمل سونار ولا بنعمل مام، بوست راديو ثيرابي ام ار اي.
بس لو
بس احنا دايما بنطلبه احنا الترند بتاعنا في ككلينيشن لا نطلب ام ار اي عشان الايه مور سبيسيفيسي ومور
هو فعلا البوست راديو ثيرابي الانفلاماتوري تشينجز اللي بتحصل دي ممكن تعمل لي فولس بوزيتيف ريزلت في الام ار، الاقي فيه ماركت انهانسمنت.
بس هو البيست موداليتي اي ثينك تقريها يا ريهام. ماشي ماشي شكرا يا ريهام.
العفو. الناس خلاص
شكرا جزيلا. شكرا يا دكتوره، ممتاز.
Dr. Riham Reda, Healthcare Quality Supervisor, Oral Medicine and Pre-Odontology Specialist. And her talk is about pro-inflammatory and anti-inflammatory salivary cytokines in breast cancer, relationship with clinical pathological of the tumor.
لا عشان بس فتح البرزنتيشن. بسم الله الرحمن الرحيم. It's my pleasure. It's my first time in the Faculty of Medicine conference. أنا أصلاً طبيب أسنان، فدي أول مرة أقول في مؤتمر طب بشري، It's my pleasure. It's my honor. Pro-inflammatory, anti-inflammatory salivary cytokine in breast cancer. This will be covered today in our presentation. Why cytokine? It's highly insoluble secretory protein that mediates intercellular communication in the immune systems. فكرة السيتوكينز أو إن إحنا ليه بنتكلم في السلايفا؟ السلايفا دلوقتي تعتبر it's a promoting field إن إحنا use it in the early detection in the multiple diseases. بالنسبة للسلايفا إحنا خدنا فيها في كليات طب الأسنان شوط كبير جدا فيما يخص early detection أو diagnosis of the diabetes mellitus and some of immunodisease and other gastrointestinal disease. In breast cancer or in cancer field is the limited study, but we have to, we hope to promoting use this kind of study in future. Sorry. The classification of cytokine. Cytokines has had multiple classification. The most common classification about the type of the cell-producing cytokine can be divided into 3 types: lymphocytokine, monocytokine, and cytokine, which produces by non-lymphocytic and non-mononuclears. And according to the mechanism of action, which is important to us today, it's pro-inflammatory and anti-inflammatory cytokines. Cytokine in cancer development. Cytokine يعتبر زي يعني ليها 2 rule. ممكن هي to promote cancer أو to defend the body against cancer. Cytokine in the cancer development تعتبر important player in the tumor initiation, promotion, and genesis of the tumor, and also metastatic. عندنا زي ما احنا قلنا ان multiple studies بتتكلم ان prominent players في releasing of the divergent cellular stress, including carcino-inducing injury, infection, and inflammations. فكرة continuous inflammation زي في الدايابيتس ان هو في continuous state of inflammation may in some cases promote cancers. Role of cytokine in different stages of the breast cancer. Cytokine has an explanation in the starting of breast cancer. A normal cell can be adopted neoplastic phenotype of the action of interleukin-6 and interleukin-1, tumor necrosis factor, and the pro-inflammatory cytokine. Increase and activate cyclin D1 in the normal breast cells. ممكن يحصل لها neoplastic phenotype. A proliferation of the cell in the early stage of the cancer suppressed في بعض المراحل بتيومر TGF. However, the later stage TGF promoting مع إنه كان في الأول بيعمل suppressed ممكن TGF beta promoting the proliferation of the cells and tumor progression. Stromal fibroblasts and CAFS are important source of TGF-B and TGF-beta, and interleukin-6 can lead to initiation of EMT process. With the end finding السيلز دي تتحول لكانسرز وليتر اون ممكن يحصل ميتاستاتيك لو ما حصلهاش early detection. بشكل سريع summarize the role of each type of cytokines in the cancer activity. Salivary cytokine in the breast cancer. Are the salivary cytokine profile of breast cancer change according to clinical pathology or character of the tumor? Study اتعملت على patient before and after the diagnosis stage and the confirm of cancer for 100 patients, 50 with a confirmative metastatic, malignance, and the other fibroadenomas. Before starting any line of treatment. Cytokine profile with correlation with the breast cancer. The pro-inflammatory cytokine in the breast cancer content interleukin 1, 2, and 3 increases, while the tumor necrosis factor MCP and interleukin 6 and interleukin 18 content decrease. Among the anti-inflammatory cytokines, the content of interleukin 4 decrease and interleukin 10 increase. In the stage of the cancer, we found that IL-1 and IL-2 with increasing in content خصوصا في early stages of the disease, then tending to decrease, and significantly statistically significant increase in more advanced stage. For interleukin cyst, يعني intend ان هو يزيد من مرحله لمرحله, والcontent of interleukin 8 and 18 decrease. Observe the tumor necrosis factor MCP decreasing في حاله لو هو cancer في early stage و increasing in advanced stage. The change of concentration of anti-inflammatory cytokines was multidirectional, or the maximum difference being observed for stage 2A. ده بشكل عام اللي هو مرحلة كل type of cytokines in the carcinoma in situ in stage 1, 2A, 2B, and stage 3 and stage 4. Cytokine profile correlation with the degree with cell differentiation of the breast cancer. There's two differences between the the differentiation of the center with the salivary cytokine. The maximum difference with the control group fibroadenoma would observe it in highly differentiation tumor, while the content of all cytokines decrease except MCP and interleukin 1. The poorly differentiated breast cancer cells has the high content of interleukin 1, 2, and 6, and also 10. The graph بيبين المعلومات اللي احنا قلناها. Cytokine correlation with the KI 67. The expression of the KI, the multidirectional natural change of interleukin 2 and 18 in the saliva, with the maximum decrease in the content of cytokine with note with the globe with low KI 67, and the maximum increasing being for globe with the high level of expression of the KI. بالنسبة HER2 ER-BR, significant increase in the content of MCP1, interleukin 1, 2, 4, and 10 found in the triple negative breast cancer for the first time. The correlation with the level of saliva of tumor necrosis factor interleukin 1 and interleukin 6 with the HER2 status, and MC1 and MCB1, 2, and interleukin 1, 2, and 4 with hormonal status of tumor. ER status had a greater effect on the content of the salivary cytokine in the saliva. X-ray increased the content of the MCB1 in the saliva was noted for ER negative tumor. Statistically significant difference between ER positive, ER negative tumor was confirmed for interleukin 2, interleukin 4. الجراف اللي بيبين الأرقام احنا قلناها. Expression دي أنا برجع معلش. A summary has been shown the content of pro-inflammatory, anti-inflammatory cytokine in the saliva correlate well with the clinical pathology character of breast cancer. The level of all salivary cytokine increased with advanced stages of breast cancer, and then the low degree of the tumor differentiation, the exception of MCB1, which is an extremely high content of well-differentiated breast cancer. Statistically significant increase of the content of MCB1, interleukin 1, 2, 4, and 10 was found in triple negative breast cancer. For the first time, the correlation of the levels, salivary liver tumor necrosis factor, interleukin 1 and 6 with HER2 status, MCB1, interleukin 1, interleukin 2, and interleukin 4 with the hormonal status of the tumor has shown the relationship between the level of the interleukin 2 and 10 and 18 in the saliva with the KI 67 expression has been established. Thank you.
دكتورة ريهام، هي المعلومات اللي حضرتك وصلت لها دي هتفيدك ازاي في عمليا يعني؟
هي فكرة السلايفا بشكل عام زي ما قلت في الأول.
بص يا ريهام، دكتورة قصدها هتفيدك ايه ان انكريز الانترلوكين يعني في السلايفا بالنسبه لنا احنا كبريستانت بروجنوستيك وبريدكتيف فاليو، هل لهم بريدكتيف فاليو؟
هي فكرة ان السلايفا السيتوكين ليها علاقة بالانفلاميشنز. الانفلاميشنز في الاورال كافيتي، انا بالنسبه لي لو بقيس انفلاميشن اورال كافيتي عنده كلوز ريليشن، لو زياده الانفلاميشن فبالتالي البكتيريال كونتنت في الاورال كافيتي ليه جريد ريليشن ما بين اول حاجه ممكن يسبب كارديوفاسكولار ديزيز مع البريست كانسر، يعني العيان هيشتكي ممكن يشتكي من هايروفاسكولار ديزيز. انكريز البكتيريال كونتنت اوف ذا اورال كافيتي ممكن تؤدي ان في ستاديز، للاسف الستاديز بتاعت السلايفا لسه في بدايتها، يعني تعتبر البيك بتاعها بدا من 2018، ليها ريليشن بالجاسترو انتستينال كانسرز. وفكره برضو ان احنا بنحاول ان احنا to understand more the nature of the cancers عن طريق ان احنا بندرس كل البادي بارت اللي بتتاثر بالكانسر.
دكتور ربيع احمد.
بس اعتقد ان الدكتوره ريهام قصدها ان لما نزيد الانفلاماتوري ماركرز ديس كود درايف ذا اونكوجينيتك او الاونكوجينز وتؤدي الى بريست كانسر، او indirect way اقيس بيها هل الاونكوجينز ار very activated in this او الميتاستاسيس اوف ذا بريست كانسر. ده رايي انا، فما اعرفش هل حضرتك ده اللي كان قصدك عليه؟
هي فكره يا دكتور برضو احنا محتاجين ان احنا الكانسرز لحد دلوقتي في اجزاء منه احنا مش عارفينها، او دايما بنقول في كلمه اتيولوجي unknown cause، فاحنا بنحاول ان احنا نستارت كل الافكت اللي بيحصل في البادي من الكانسر.
هي ممكن تكون حاجه للفيوتشر، لان المايكروبيوتاز دلوقتي ار جيتنج انتو ذا كانسر، فبالتالي هل البرو انفلاماتوري ماركرز دي هتزود المايكروبيوتاز leading to يعني حاجه maybe this is حاجه لسه translational rather than applicable يعني.
سألني السؤال بيقول لي تايب اوف انترفيرون كل واحد بيشتغل ازاي؟ فكده اتفضلي يا ريهام اتفضلي. حضرتك قدمت يا دكتور؟ يا دكتور حضرتك متقدم حد يا باشا.
It's a pleasure to introduce دكتورة تماضر الهادي عثمان. دكتورة تماضر موجودة؟ اتفضلي. She's going to talk to us about something expression in breast cancer in Sudan and literature review. معلش أنا جراح مش عارف الترم ده.
أنا كمان جراحة. لا أنا سودانية. أيوة. السلام عليكم. My name is Tamadur Al-Hadi. I'm general surgery specialist from Sudan. مش واضح؟ I'm Tamadur Al-Hadi, general surgery specialist from Sudan and surgical trainee at Bahia Hospital. It's a pleasure to talk to you today with my talk about ApoBec3B expression in breast cancer in Sudan and literature review. So during the next few minutes, I will be discussing with you or introducing to you ApoBec3B and why it is significant in breast cancer. Then I'm going to discuss with you briefly the literature review and the updates. And I will share with you my experience about ApoBec3B expression among Sudanese, and we end with a summary. All right, so ApoBec, it stands for apolipoprotein B messenger RNA editing enzyme, catalytic subunit 3B. So basically, it's an enzyme with catalytic activity. So ApoBec3B is a member of a large family of enzymes called ApoBec, and it's essentially working in the innate immune response against viruses. But on the other hand, it also has a mutagenesis effect, and it does affect cancer development. And this family has been implicated with many types of cancers, including colon cancer, lung cancer, head and neck cancer, and of course, breast cancer. And that will be the focus of my talk. All right, so when we study breast cancer at molecular level, and by molecular level I mean at the level of the DNA, RNA, and proteins, we find that breast cancer is extremely heterogeneous disease, and genetic mutations serve crucial role in the development and progression of this cancer. And thanks to the genomic DNA sequencing, that has enabled us to identify these mutations and the pattern of it. I'm sorry. So in large-scale genome sequencing studies has indicated that there is a cluster of mutations in breast cancer contribute to the progression of the disease. And by clusters, I mean there is a repeated mutation that share the same pattern. They call it catagenes. And ApoBec3B has been suggested to be implicated in this somatic mutation because it carries the signature of it. So to confirm that ApoBec is causing this kind of mutations, they have measured the messenger RNA expression level of it, and they found it to be high. And as we can see here in this genome sequencing, there is a repeated pattern called the catagenes. That's what ApoBec does in the genes. So the molecular study suggested that ApoBec is not just acting against viruses in the innate immune response, but it's also a mutagenic gene or enzyme. So as we can see here, in primary breast cancer, ApoBec contributes significantly in the mutagenesis of the disease. However, in the metastatic breast cancer, we find that ApoBec almost causing 50% of the mutations that we see in breast cancer. And for this, we think that ApoBec3B is a key factor for cluster mutations in breast cancer, and this might partially explain why we get poor response to the single target therapy, because we're not targeting the right genes. And subsequently, clustered mutations caused by ApoBec3B might work or pose as a biomarker for prognosis of breast cancer. So when we look at the literature, we find that ApoBec3B is a hotspot and has been investigated thoroughly, but yet there are so many questions to be answered as well. All right, so in this nice and significant study that published by Breast Cancer Research Center, they found that ApoBec overexpression correlates with poor outcomes, and they suggested that we can use it as diagnostic and prognostic gene, and also it can be a candidate for target therapy. Another interesting study from China confirming the same result, that ApoBec overexpression correlates with poor outcomes in the lamina A subtype. And in the United States, they reported that ApoBec has been implicated in mutation heterogeneity in the pre-invasive cancer as well, like in carcinoma in situ, ApoBec is implicated as well. Now, ApoBec is not a mutagenic gene by itself, but it's also affecting another member of its family called ApoBec3A, which is another mutator. So it has a direct and indirect effect on cancer development and progression. Now, going back to this interesting study, we find that they have mentioned a very interesting point, which is ApoBec expression varies among populations. It is overexpressed in some populations and down-expressed in the others. And that has made us to question how the situation in Sudan, and we as a population, has ApoBec overexpressed or down-expressed. So to answer this question, we conducted this study. And before I go into the study, just a bit of disclaimer that this paper has been a product of a teamwork that has been led and supervised by Professor Muntasir Ibrahim. He's a pioneer genetic researcher and very well known for his contributions, and this is my team. Now, to conduct this study, we included patients who we have adopted a case control study design, including females who has been diagnosed histologically with invasive breast cancer and planned for upfront mastectomy. And to collect the samples, we went to the operation room, and after mastectomy, immediately we collected fresh tissues. And by fresh, I mean not formally embedded. So we took samples from the core of the cancer and another sample from the periphery of the mastectomy specimen to act as a control. And over a 2-month period of time, we have only been able to collect 11 samples. And from theater, we went directly to molecular lab and underwent the molecular test using the chloroform method for RNA extraction, and then the multiplex to convert RNA into cDNA, and finally, the real-time PCR to replicate the gene and measure it using the primers and beta-actin as a reference gene. So the expression level of ApoBec has been measured using the delta-delta threshold cycle method, and this table summarizes the real-time PCR findings. And overall, ApoBec3B has been overexpressed 3.5 times higher in breast cancer tissues compared to normal breast tissues. And by this, I come to the end of my presentation, and my summary and take-home messages will be: ApoBec is a brand new defined source of DNA damage and mutation in breast cancer, and it has a considerable role in breast cancer heterogeneity, and the high levels of its messenger RNA correlates with poor relapse-free survival, poor distance mets-free survival, and poor overall survival, in particularly for the lamina A subtype. ApoBec has both diagnostic and prognostic potentials, and it is a promising marker for immunotherapy and targeted therapy. Thank you.
دكتورة تومادر، هل الكوست بتاعته يعني نقدر نعمله ولا تكلفته غالية؟
هو expensive صراحة. عموما الموليكولار تيست هي very expensive. احنا في الاستادي دي we use the multiplex يعني design in molecular. Now حصلت advances في الفيلد دي اللي هو عندنا just like a ready-made kits. We can use it in single step. لكنه very very expensive. يعني ال one sample will cost a lot to be tested. Sorry? لا نقدر نطبقه طبعا، بس محتاجين فند يعني بكميه كده يعني معقوله.
سؤال دكتوره تماضر، انت ايوه انا معاكي.
سوري.
You are general surgeon.
I'm a general surgeon.
ايه اللي ضافوه لك ده كجراحه؟
جراحه.
كجراح يعني انا بوينت اوف انترست بالحته دي، ايه اللي فرق معايا كجراح ليك انت كجراحه؟
alright كجراحه انا يهمني انه العيان بتاعي بعد ما يخلص مني، يعني بعد ما عملت له الاوبريشن اللي انا يعني whatever for breast conservative or mastectomy، هو هياخد adjuvant therapy. في adjuvant therapy دي it will affect the long term outcome for patients. It's not directly related to surgeons، لكن I'm just interested in cancer genetic researches, so I'm just conducting this kind of work.
تومادر، هو حضرتك عملت كام حالة يعني؟
11 samples.
11 samples
over 2 months period. الكولكشن ما كان سهل لأنه it wasn't easy إنه to correlate مع السيرجون. يسمح لك إن أنت to open mastectomy specimen and take from the core, and before that you need to correlate with the histopathology lab that we're going to do this in the sample, so it won't interfere مع السكشن margins.
Thank you دكتور تومادر.
Thank you.
وما كانش ينفع تعمليها على البارافين سكشنز؟
Sorry؟
البارافين سكشن يعني تعمليها ريتروسبكتيف.
لو كنا بنشوف البروتين ممكن، لكن المسنجر RNA should be in fresh tissues.
Thank you. I liked your presentation very much.
Thank you.
Have you correlated with, with the luminal subtypes of breast cancer? For example, the triple negative, the hormonal positivity. First of all, have you correlated this also with the poor risk factors like the lymphovascular invasion, grading of the pathology? Because yes, it's promising, yes, it's good, but again, did you correlate with others? Because also, if you do later on, I know PCR is expensive, but if you do NGS, you might correlate this overexpression with another expression of like P53, for example.
Yes, exactly.
I mean, I'm just talking theoretically.
Yeah.
But
okay.
Have you correlated clinically?
Clinically, you mean with the receptor status and K? Okay, according to literature, yes, it is correlated with the lamina A subtypes. If this gene is overexpressed in the lamina A subgroup, it will end with a poor outcome in the long term. But in my study, no, I haven't done that because the sample size was very small, so I couldn't do.
No, it's very easy because if you extract the mRNA and then you do have the pathology report later on from the biopsy, then you can know the luminal subtype of the patient.
Exactly, sure. So that's possible to be done, but I couldn't finish my study because the unstable situations in Sudan, so we just end with that.
دكتورة تومادر، آخر يعني حاجة، معلش أنا عارفة إن الوقت أنا I liked your presentation. يعني أنا مش عايزة أسأل على لجنة الحكم بس يعني I think this is the novelist one في اللي اتقدم النهاردة. اديتينا فعلا حاجة جديدة.
Thank you.
هي الفكرة بس معلش maybe I missed this in your presentation. الكيسز دي معمولة في السودان ولا معمولة فين؟
معمولة في السودان.
معمولة في السودان.
في الخرطوم.
والكوست كان قد إيه لل 11 cases دول in dollars؟
ما اقدرش اقول لك بالظبط كان يعني الكوست كام بالظبط لانه البرايمرز هي اكثر حاجه اكسبنسيف واحنا وي اوردرد فروم تشاينا. فالبادجت كلها كانت تبع انا كنت بعمل في ماستر دي ماي ماستر بروجرام.
فكان بروجكت يعني كايند اوف بروجكت يعني
كان بارت اوف ماي بروجكت
وفاندد بروجكت.
فالانستيتيوت هو اللي كان بيقوم بالفند دي.
اوكي ثانك يو.
ثانك يو.
I'd like to introduce Dr. Yasmin Hani, lecturer of general surgery in Shams University. She will introduce a comparison of wire-guided localization and radio-guided occult lesion localization in localization of non-palpable breast lesion.
Comparison of wire-guided localization and radio-guided occult lesion localization. Comparison of wire-guided localization and radio-guided occult lesion localization in localization of non-palpable breast lesions. The number of patients with non-palpable breast lesion has increased gradually. This is because of the technological development in imaging techniques and screening program that lead to early detection of breast lesions. The aim of marking of non-palpable breast lesion is to achieve accurate lesion localization to obtain better cosmetic result with less tissue loss and to provide negative surgical margin. Wire-guided localization is the most common localization method, which was first described at 1965. Some modification has been made over the last years. Advantage of wire-guided localization are the widespread availability and moderate price, but it has some disadvantage. The surgeon should follow the wire tip to reach the lesion, and this causes excessive excision of healthy tissue. Wire placement technique is time-consuming and difficult, especially in dense parenchyma. The wire should be kept in place until the operation time. This may cause discomfort. The wire may be migrated, transected, or displaced. The wire tip doesn't give indication about the lesion extension, and surgeon estimates the amount of tissue to be removed intraoperatively. Radio-guided occult lesion localization is a recent technique, which was first described in 1998. In this procedure, radioactive material is injected under image guidance in the lesion, and we use gamma probe for excision. Roll has gained more advantage during the last decade, such as more rate of clear margin, reduction of excision volume, good cosmetic outcome, better lesion centricity in surgical specimen, and simultaneous sentinel lymph node localization, which is called SNOL. Aim of our work: we compare the post technique with compare wire-guided localization and roll to assess their accuracy, efficacy in non-palpable breast lesion localization. And we also compare post technique as regards complication, clear margin, and reoperation rate. These retrospective studies carried out in Bahia Hospital from Jan 2018 to June 2022. We included patients who are more than 18 years old with non-palpable breast lesion and candidate for breast conservative surgery. 670 patients were enrolled in this study, and they divided into two groups. Roll group included 320 patients, and wire group included 315 patients. We will talk about the localization technique for roll group: injection of technetium colloid albumin in the lesion under image guidance. For example, 43 years old female come for a screening program. Her sonomammography revealed lesion, focal asymmetry in lower inner quadrant of the left breast. And so role-guided localization was done, and stereotactic guided injection of radioactive material was done as in image C. Postoperative pathology revealed usual ductal hyperplasia. As regard wire localization technique, the wire was preloaded in the needle introducer. When the tip is just beyond the lesion, the hook is deployed by fixing the needle with one hand and advancing the wire with the other. The needle is then removed over the wire. For example, 45 years old female come for screening program, which sonomammography revealed focal asymmetry in upper outer quadrant of left breast. Stereotactic biopsy revealed sclerosing adenosis. So stereotactic wire-guided localization was done as in image C. Our results. There were no difference between the two groups in the term of age localization technique. Both localization time and time of operation were significantly decreased with roll group. The removed breast tumor was smaller in roll group. Complete lesion excision with clear margin were reported in 119 from 135 malignant patients in roll group, while 130 from 159 malignant patients in wire group. And reoperation rate were 16 patients in roll group compared to 29 patients in wire group. In roll group, we also sentinel lymph node identified in 105 patients. Regarding cosmetic outcome, 39 patients has excellent outcome in roll group, while 85 patients has excellent outcome in roll group. As regards the scar length, which was significantly decreased in roll group. Conclusion, the roll is effective as wire for non-palpable breast lesion localization. Also, roll improves the outcome by decreasing the duration of surgery, localization time, achieve high percentage of clear margin in spite of lower specimen size and scar length, and avoid complication as wire displacement. In addition, sentinel lymph node biopsy can be performed during the same procedure. Therefore, we suggest roll is an effective alternative to wire in non-palpable breast lesion localization. Thanks.
يا دكتورة ياسمين، هو حضرتك بتعملي الستيريوتاكتيك امبلانت ازاي؟
الواير؟
ستيريوتاكتيك امبلانت، انت بتقولتي ان في تكنيك بتستخدميه بتحط الواير ثرو.
مش يعني الراديولوجيست مش انا.
عندكم الجهاز ده؟ الجهاز موجود؟
موجود في بهية.
ثمنه كام يا ياسمين؟
لا مش عارفه.
دكتور احمد مجدي، الستيريوتاكتيك اللي عندكم الجهاز اللي هو بتستخدمه في الواير بكام؟ ثمنه كام؟ طب مين راديو ثيرابي عندكم يا باشا؟ اتفضل.
هي الفكره ان هي الراديولوجيست قبل العمليه بيحقن تكنيشن جوه الليجن ده في الرول، وبعد كده السيرجن بيشوف الحته راديو اكتيف على البريست، يبقى جايدد بجاما بروب عشان يوصل للتيومر فيرسس الواير. هي طبعا هي ليها مشاكل كتيره برضو على فكره، ان هي العيان بيروح الاول راديولوجي ديبارتمنت وبتحضري الداي ومش عارف وايه والبريكوشنز اوف راديو اكتيفيتي ومعاملتك مع السبيسيمن ومعامله الباثولوجيست مع السبيسيمن، فكل الحاجات دي برضو برضو تبقى ادد towards the negative side بتاعت الرول. خلي بالك مش كده بيه؟
ليه؟
يعني انت بتعرض نفسك، بتعرض الطقم كله معاك لاشعاع بدون اي
بس هو في مشكله في الواير، وعلشان كده لازم ندور على حلول بديله. الواير بيغير، يعني ممكن الراديولوجيست هو عايز يرمي لك الواير على الليجن، لكن مش عارف انت بتديزاين الانسجن بتاعك ازاي.
والمشكله كمان في المارجن،
فممكن يخليك تغير الديسيجن
المارجن كمان
بلس المارجن. ولو في كليب ممكن الواير ما يبقاش على الكليب على طول، تبقى انت محتاج جوه.
Last but not least, Dr. Yasmin Yasser, Medical Oncology Assistant Lecturer, National Cancer Institute and Bahia Hospitals, and she's going to present male breast cancer in Egypt.
Good afternoon, everybody. I'd like to start my talk today about rare entry of breast cancer in Egypt. We'll be talking about male breast cancer in Egypt. As we all know that male breast cancer is a rare disease and little is known about male breast cancer, and most of the information that we do have comes from the female breast cancer data and studies, and most of male breast cancer studies are very small and commonly retrospective and single institutional studies. And as we all know that we do have many risk factors for breast cancer. In male breast cancer, age, race, and family history are the most important risk factors for male breast cancer. Let me talk a little about the latest study in 2022. This study showed that this study compared female breast cancer patients with male breast cancer patients, and we found that male breast cancer suffered from high TNM staging, higher tumor grade, and higher percentage of hormone receptor tumors. That's why female breast cancer patients were associated with superior overall survival rather than the male breast cancer patients. We have a little question about the TNM staging in the male breast cancer. Due to the little breast tissue in the males, most of the cases and almost more than 40% of the cases present with advanced stage 3 and stage 4. That was the issue, and the question whether the TNM staging will be suitable for male breast cancer, or should we produce another staging for male breast cancer. Regarding the treatment paradigm for male breast cancer, it's almost similar to the female breast cancer. In early breast cases, go for upfront surgery followed by adjuvant treatment. In locally advanced HER2 positive, triple negative would go for neoadjuvant therapy followed by surgery and adjuvant treatment. And for metastatic disease, we go for hormonal treatment first line unless we have visceral carcinoma. We will go back to our study. Our study was a retrospective study, and we studied 48 male breast cancer patients who presented to the National Cancer Institute from 2010 to 2021. All the data were retrieved and we assessed almost all the factors: etiology, clinical features, presentation, treatment, prognosis, and survival. And we found that the mean age of our patient was 60 years with median age 48 years. And we found that 45% presented with advanced stage. However, we found that we were having a comparable mortality with female breast cancer after a comparison with the latest study published in the last ASCO by Dr. Hamdi Abdelazim. We found comparable overall survival between male and female breast cancer in Egypt. And we found that the most important prognostic factors were stage at diagnosis and lymph node involvement in surgery. And to discuss the results in detail, we found more than 50% of the cases presented with age less or equal 60 years. Almost 90% were having invasive duct carcinoma, and most of the patients, almost 95%, were ER and PR positive. Regarding the tumor grade, we found almost more than 90% were having higher tumor grades. Regarding the HER2 positive, only 8% of the cases were HER2 positive. Regarding the staging, almost 90% of the cases were stage 2 and stage 3, with only 8% who presented initially with stage 4. Regarding the T stage, almost 75% of the cases were pathologically T2. And regarding the lymph node status, almost a third of the patients were lymph node negative, while the other 2/3 were lymph node positive, and mostly N1 and N2. Regarding the management, we found that almost 80% of the cases underwent upfront surgery, and the rest 20% received neoadjuvant treatment. Regarding the type of surgery, almost 60% underwent wide local excision, while the other 40% underwent mastectomy, whether sample or modified. Regarding the adjuvant treatment, we found that 75% of the cases received adjuvant hormonal treatment, and 50% received adjuvant chemotherapy, and almost 70% received post-operative radiotherapy. Regarding the local recurrence, we found only 8% with local recurrence and almost 30% with distant relapse rate. And regarding survival, we found the median overall survival was 85 months, and median disease was almost 71 months. And stage affected survival with early breast cancer, median overall survival almost 90 months versus 70 months in locally advanced. And as we all see in these tables, that stage and the diagnosis was affecting survival and affecting recurrence, with 13% of the cases developed recurrence in locally advanced disease versus only 4%. Regarding post-operative radiotherapy, we found that it didn't affect survival in early breast cancer, but affected survival in locally advanced breast cancer. And to conclude, male breast cancer is rare with possible genetic predisposition. And as we all know, the standard treatment for early disease is surgery followed by adjuvant treatment, and locally advanced disease is neoadjuvant treatment followed by surgery and appropriate adjuvant treatment. And in metastatic disease, first-line hormonal treatment is the first-line therapy unless we have a visceral crisis. And this study, after this study, I recommend and we recommend future research for better understanding of the disease and increasing the awareness about male breast cancer, because almost 50% of the cases present with advanced disease because they lack the awareness about the possibility of breast cancer in males. And finally, the latest NCCN guidelines recommended annual clinical breast examination for male patients with BRCA, for male population with positive BRCA mutation. Thank you.
الدكتور احمد بيه عاوز يقول كومنت. الدكتور رحيم ماشي. خد اديله المايك.
I would like to ask the surgeons. I've noticed that the wide local excision in male breast cancer, is it possible? I mean, there is no space to take no tissue. Yes. But not wide local excision, right? Because most of the patients here were wide local excision. So my question to the surgeon. Okay, thank you.
هو بس يا دكتورة ياسمين حضرتك دكتورة ياسمين حضرتك انت كتبتي ميل بريست ان ايجيبت، معناها ان انت عملتي احصاء لكل مصر كلها ولا عملتي؟
لا in the National Cancer Institute.
طيب يبقى تكتبي
هغير حاضر.
ما فيش كده يبقى احنا بنخلط الموضوع. عاوزه قولي للمعهد القومي، لكن ما تقوليش ان ايجيبت.
حاضر.
ما فيش احصائيه دقيقه يبقى ايه، علشان ان ايجيبت دي شامله كل حاجه. حاضر. شكرا يا ياسمين. شكرا.
سؤال، مش انت انكولوجيست؟ حضرتك انكولوجي مش كده؟
يس.
ايه الفرق؟ عشان شفت انت كاتبه لاتراليتي الرايت ليتل بيت مور عن الليفت.
يس.
ايه عيب الرايت بريست كانسر وايه عيب الليفت بريست كانسر؟
أنا بس مش سامع آخر سؤال، معلش.
What is the problem with breast cancer on the right side and what is the problem of breast cancer on the left side?
In the latest study I've discussed in 2022, they found that laterality affected the prognosis. I don't know why. They didn't mention, but laterality affected the prognosis, and they found that right breast cancer cases in males were having poorer prognosis. I don't know why, and they didn't discuss this, but we found that we're having equal distribution for laterality in our patient, almost equal distribution.
Thank you.
Anytime.
هو دكتور علاء موجود ولا ايه؟ لا معلش، المسافة بعيدة، 6 ولا 7؟
9 ساعات كمان.
Is contrast enhanced spectral mammography good imaging modality for predicting the accurate breast tumor size? By Dr. علاء زيديان.
Introduction. Breast cancer remains one of the leading causes of death in women. Recently advanced in breast imaging have been remarkable. It is essentially to ensure effective diagnostic procedures, early diagnosis, and optimal treatment planning. Tumor size is relevant in prognosis for surgical treatment, particularly conservative surgical technique, breast conservative technique versus mastectomy. Prescribed the size of the important in guiding patient towards the proper therapeutic approach. MRI of the breast is more accurate in assessing dimensional accuracy of the lesion when compared with conventional diagnostic methods such mammography and breast ultrasound. MRI has limitation, including high cost, and cannot be used in patients with pacemaker and long duration of exam. Contrast enhancing spectral mammography represents a novel reliable imaging adjacent for accurate and correct definition, estimation, dimensional extent of the breast lesion. Contrast enhancing spectral mammography is the developed technique used for differential enhancement iodine contrast between the neoplastic and healthy tissue, and doesn't suffer from typical MRI clinical limitation, high cost, high time, and long examination time. Aim of the study: to Here's the accuracy of the mammography and ultrasound and breast MRI regarding the size estimation of the breast lesion for the surgery. And the post-operative histopathology was used as the gold standard. We prospectively 158 female patients with biopsy proven breast tumor in period between January 22 and February 22-3, and breast tumor dimensions were determined by breast imaging modalities, ultrasound, mammography, contrast mammography, and MRI. Imaging breast tumor dimensions were compared to the accurate pathological size. The median age of the patient, it is about 50, and the main type of the lesion presentation was in the form of the mass, and less frequency was microcalcification. 70 patients had pyrites for A, and 35 pyrites for B, and 85 pyrites for 3, and 31 pyrite 5. Most lesions had glandular breast with ACR class A or D. Most of the lesions on the contrast examination had minimum background enhancement. The most common histological type are obtained at the surgery was invasive ductal carcinoma. And this is a table summarized of the histological result obtained at the surgery. Most common is the invasive ductal carcinoma and then invasive lobular carcinoma. And median tumor size measurement was respectively about 15 and using contrast enhancement and the surgery. Table 2 distribution, the tumor size measurement using contrast enhancement and ultrasound and mammography and MRI and surgery as a gold standard. We found no significant difference were found in the measurement of dimensional size between contrast enhancement and surgical. The mean difference is 0.18, and in MRI was surgical. The mean difference is 0.43. On the other side, significant difference was detected between the size measurement as the surgery with ultrasound and mammography. Difference between size measurement using contrast enhancement mammography and ultrasound and mammography and MRI and size measurement at the surgery as the gold standard. The case, 50 patients with present lesion as the right upper outer quadrant. With the surgery, it is infiltrative ductal carcinoma, and histological diameter it is the 22, and craniocaudal dimension for contrast enhancement mammography show nodular mass contrast enhancement with the diameter 22.3, and post-contrast T1 sequence show nodular contrast enhancement with maximum diameter 22.7. In ultrasound scan, we presenting as inhomogeneous solid mass lesion with maximum diameter it is 90, and mammography identification of speculated radiopaque nodule in the maximum diameter it is 18. Discussion. We assess the reliability of the contrast enhanced mammography and the mammography and ultrasound and MRI in measurement of the breast lesion diameter with the histopathological result of the surgery as the gold standard. Preoperative definition of the extent of the breast lesion is critical for proper surgical planning. Consider undistributed advantage of the conservative surgery. However, mammography and ultrasound is not always reliable in definition the extent of the breast lesion, especially in women with dense glandular breast tissue or implant. MRI is more accurate in definition the extent of the lesion, but it's much more expensive, can be not performed in all patients, and is highly affected by background and has many false positive results. Contrast enhanced mammography recent developed methods and alternative option to MRI, especially in those patients who cannot undergo breast MRI. Contrast enhanced mammography is cheaper, faster to perform, and less prone to background and false positive results. For our study, it seems that the reliability of the contrast enhanced mammography in measurement of the breast lesion is superior to the mammography and ultrasound and are similar to the result of show. Thank you.